Good afternoon. My name is Crystal Mutter, and I'm a psychiatric mental health nurse practitioner student at Western Kentucky University. Today, I will be presenting a psychotherapy case study on a 40-year-old male patient exhibiting symptoms consistent with general anxiety disorder. My proposed treatment plan utilizes acceptance and commitment therapy, or ACT, as an evidence-based approach. The patient's chief complaint is pervasive and chronic, stating, "I can't turn my brain off at night and I'm always on edge. I feel like something bad is about to happen." Well, this highlights his chronic sense of threat and cognitive hyperarousal. From a PMH&P standpoint, this patient is presenting with chronic, excessive, and pervasive worry that has persisted for over 6 months. His current symptoms, including hypervigilance, motor tension like jaw clenching, and significant insomnia, are causing noticeable occupational and social impairment in his life as a sales manager. The patient's work in a high-stress sales environment or key stressors include a recent divorce 6 months ago and a strained relationship with his older brother, both of which likely contribute to his sense of instability. He does have a past history of unspecified anxiety, noted in adolescence, suggesting a predisposition, but no formal past treatment. A substance abuse use, a critical piece of information, is his occasional cannabis use, which he uses to calm down and aid sleep. It's important to note that his anxiety symptoms clearly preceded any heavy use, suggesting that cannabis is a form of self-medication and not the primary cause of the anxiety itself. His clinical presentation is consistent with general anxiety disorder, showing excessive worry over multiple domains, work, finances, and his son's well-being, along with somatic symptoms like muscle tension, fatigue, and persistent insomnia. His low mood is secondary to the chronic anxiety and resulting sleep deprivation. Based on the DSM-5 criteria, the primary diagnosis is general anxiety disorder, chronic moderate. It is chronic because the symptoms exceed the 6-month threshold, and moderate due to the clear functional impairment in his work and social life. He meets criteria for excessive anxiety and difficulty controlling worry, along with the required 3 or more associated symptoms like restlessness, easy fatigability, sleep disturbance, and muscle tension. The differentials ruled out are substance-induced anxiety, as his anxiety symptoms were present before his attempts to self-medicate with cannabis, and also excluded social anxiety disorder because his worry is not confined to being judged or performing socially, but is generalized across all major 3 domains. The proposed psychotherapy is acceptance and commitment therapy, or ACT. The overarching goal of ACT is to enhance psychological flexibility. This is achieved by increasing his capacity to accept difficult internal experiences, his worries and physical tension, rather than fighting them. This acceptance allows him to commit to values-driven actions regardless of his emotional state. ACT is a highly effective third-wave cognitive therapy for GAD. Its EPB status is supported by the Trizona Study 2023, which is a recent meta-analysis, which demonstrate its efficacy in reducing anxiety and improving quality of life by focusing on long-term process-based changes. The theoretical underpinnings of ACT is theoretically grounded in relational frame theory, or RFT, which suggests that human language allows us to create powerful, often unhelpful verbal rules, such as "I must solve this problem to feel safe." The patient is psychologically stuck because he treats his worried thoughts as literal facts that he must control, which leads to avoidance and increased tension. The model application, we apply the trans-theoretical model, or stage of change, to assess his readiness, and the patient is likely in the contemplation preparation stage. He recognizes his chronic worry is a problem and is seeking help, but he's not yet committed to changing the avoidance behavior. behaviors, such as using cannabis for sleep. Our interventions, therefore, must focus on highlighting the cost of his current behavior to motivate him towards the action stage. The treatment strategy is a combined approach of acceptance and commitment therapy techniques and pharmacological management evaluation. We focus on 3 key ACT interventions: values clarification. Start with an exercise like the bullseye to help him identify his core life values, such as being a present father or demonstrating integrity in his work, which will then serve as the compass for his behavioral change. Move on to cognitive diffusion. Next, we implement the cognitive diffusion to weaken the literal hold of his worried thoughts. We'll use techniques like I'm having the thought that, or thanking the mind to create distance, thus reducing the perceived importance of the worry. Committed action or behavioral exposure. Finally, we could schedule committed action. These are small, values-consistent behaviors like calling his son that must be complete despite the presence of anxiety. This is a form of behavioral exposure where the commitment to his values overrides the urgent to avoid. So what are the expected therapeutic outcomes? They're specific and directly related to the ACT process. Our goals are for the patient to achieve value identification. Within 4 sessions, the patient will identify 3 core life values, be able to articulate how his current avoidance behaviors conflict with these values. Committed action. He will successfully complete 2 values, consistent actions weekly, regardless of his anxiety level. And diffusion success. He will utilize diffusion techniques to rate the believability of worried thoughts as less than 5 on a 10-point scale, at least twice weekly. The overarching outcome was the ultimate goal is an improvement in his overall quality of life and a measurable decrease in his GAD-7 scores by 50% within 12 sessions, reflecting increased psychological flexibility.